Hi everyone, welcome back to a new episode of Reframe Your Health. I'm Dr. Yusuf. Beside me, as usual, my co-host Dr. Labib. And today we're going to talk about gynecologic cancers. And for that, we have a very special guest, a colleague, a friend, and the chief of Gynecologic Oncology at the University of Miami and Sylvester Cancer Center, Dr. Sinno. Dr. Sinno, welcome, and thank you for coming today.
Thank you for having me. It's a pleasure to be here, Yusuf.
Welcome, Dr. Sinno. So to start, we're talking about a very dangerous disease we call cancer. Everybody's afraid of it. So can you just let us know when we talk about gynecological cancers, what are those cancers? What are we talking about?
Absolutely. So cancer in general is a very feared word, and I think the more we identify and the more we know about these things, the less fearful we are, and we can transition into a place of making a plan and acting upon it rather than coming from a place of fear. So when we talk about gynecologic malignancies in the United States, those are specifically what we call below the belt cancers for women. So in Europe, that includes breast cancer, but in the US, it's below the belt. So ovarian cancer, cervical cancer, endometrial cancer or uterine cancer in general, vaginal cancer, and vulvar cancer.
So our goal today is basically to reframe and look at cancer from a different perspective. Look at risk factors, things in our lifestyle, talk about the new therapies, new surgical techniques that are out there. So if we start by what are the things that we do in our daily life, we talk a lot about toxins causing diseases. Are they related to cancer, like endocrine disruptors? Are they related to cancer?
Absolutely. So in general, when development of cancer requires a mutation in the genetic code of the cell, of normal appearing cells, and that causes cells to start multiplying at an aggressive rate and invading, whereas otherwise they would be sitting neatly within their infrastructure, if you will. So there are many ways for this genetic mutation to occur. Sometimes, in some cases, the reasons for this genetic mutation is hereditary, and we see this with hereditary syndromes like BRCA mutations or Lynch syndrome or any of Cowden syndrome, any of the syndromes that are genetically passed on from family member to family member. There are other causes, which are environmental causes. Someone who is not at a predetermined or a known predetermined risk of cancer can have exposures during their lives, whether they're internal or external exposures, that cause cancer. So for example, internal exposures could be, for example, women who have PCOS that's unmedicated, who don't have regular periods. Those patients are at higher risk for endometrial cancer. External exposures, for example, are things like for certain toxins like asbestos, for example. Asbestos is linked to multiple cancers in the human body, including mesothelioma, and some reports about its link to ovarian cancer as well. Or there are many other exposures that can occur. So whenever we're talking about toxins or mediators of cancer, we have to break it down into external exposure and internal exposure. And when we think of external exposures, it's not just elements or preservatives or fertilizers. There's also environmental exposures that are related to where you live and how you live, what you ingest in your body, smoking, your exposure to certain viruses. So for example, cervical cancer is 99% mediated by the HPV virus.
That was my question, like why do some people that have HPV develop cervical cancer and some don't?
So in some cases it's very clear. So HPV is a virus. When you get the flu, which is another virally mediated cancer, your body fights the virus out. The virus incorporates into your cells and your immune system, your cell-mediated immunity attacks and kills the virus and the cells that are infected with this virus. HPV is in the same mechanism. It infects about 80% of women in the US have had exposure to HPV. Obviously not everyone will develop cancer. It's actually not the infection with HPV that causes cancer, it's the persistence of the infection in the human body. So some patients who are immunosuppressed, who have this cell-mediated immunity suppressed secondary to either smoking, secondary to being on immunosuppressive drugs, like for example, women who have rheumatoid arthritis or women who have HIV or AIDS actually, those patients have a deficiency in their cell-mediated immunity and their ability to fight the virus out of the body is diminished. And so the virus persists in their cells, and that persistence will cause an alteration in the genetic code of the cells of the cervix or the vulva, for example, as well. And that will lead to dysplastic changes that ultimately lead to cancer. By dysplastic changes, I mean changes that make the cells not look like what they're supposed to look like. And then for some patients, they have no risk factors other than the fact that they were exposed to HPV, and there's some unidentified reason as to why the HPV persists in their body versus others. We've done quite a bit of research on this. There's for example, some of the, and this is not meant to be universal, but for example, there are certain cultures that utilize a certain type of herbal vaginal douche, and that's been shown to increase the susceptibility of cervical cells to be infected and with HPV and for that to persist. There are smokers, for example, they have a significantly higher risk of this happening.
So as Labib mentioned, there are different types of gynecologic cancers also, as you mentioned that. And the fear that goes along with cancer, and I guess like the main question that people want to know is like, what can somebody do to prevent or to lower the risk of getting a gynecologic cancer? They're different, obviously, but what are certain things that they can do to lower their chance of getting a gynecologic cancer?
That's a great question that we could spend 6 hours on. But in short, every one of the gynecologic cancers has different risk factors and different ways to prevent it because the risk factors are different. So for example, with cervical cancer, more than 99%, as we said, are HPV related. The best way to prevent it, we used to say pap smears and HPV screening, but actually the best way to prevent it is to get get vaccinated. And the guidelines for vaccinations used to be for girls age 9, boys age 11 until age 25, and now we've expanded it to age 45, to age 27, now we've extended it to age 45. But that's the first and foremost thing that you can do for yourself.
People are always afraid of vaccines, but honestly, this is the only vaccine that prevents a cancer. We don't have any other vaccine. I know there's a lot of vaccines in the works, but this is the only one that's available now that can prevent cancer.
For gynecologic cancers, that's true.
Yeah, exactly.
In other cancers, for sure, there are some vaccines that can prevent, especially gastric type cancers and that sort of thing. But for gynecologic cancer, this prevents cancer. And there's no controversy about this vaccine. One thing very unfortunate that happened, first of all, the US has the lowest rate of vaccination of any industrialized nation. Like when you look at a country like Sweden or Norway or Scandinavia or France, their vaccination rates are greater than 95, 97%. HPV vaccination. Yeah, we're talking specifically about HPV vaccination. In the US, it was already low. We're talking about 70% penetrance. And after the whole debacle with the COVID vaccines, people became very afraid of any vaccination. And just to be clear, the COVID vaccine is a traditional vaccine. It's not an mRNA-developed vaccine. So this is the same. Yeah, the HPV vaccine is a traditional vaccine. It's not like an mRNA vaccine like the COVID vaccine. So there was really no controversy about the development of this vaccine, other than the fact that it didn't encompass every kind of HPV, and it's not universal. But it significantly reduces your rate of getting cervical cancer. It lowers your rate of getting vulvar cancer, and even it reduces the rate of getting genital warts, for that matter. And to be clear, it's not just girls that need to be vaccinated, because the girls are getting the cancer older in life as women, cervical cancer. Boys are transmitting the virus as well. So for men, men can have HPV infection, whether it's in the form of warts or it can even develop as penile cancer. But penile cancer is a very rare cancer, so it's not as present for men in their psyche. But if you vaccinate boys, you're also protecting the girls.
Yeah, I mean, we can also take the example of Australia. They've mandated the HPV vaccine for quite a bit of time, and they're on track of kind of almost eliminating cervical cancer. And just the take-home message for vaccines and the HPV vaccine, it's one of the most preventable types of cancers, and not all vaccines are the same. HPV vaccine is completely different than the mRNA vaccines that there's a fear, controversy about them. It's not the same. It's not like the mRNA vaccines, and it's there's safety data on it that's safe.
Yeah, this isn't a new vaccine. This has been going on since before any of us were in training. So maybe since when we were in training. And that's a long time. I'm aging ourselves right now, or dating ourselves. But the truth is, there's no controversy about the safety of these vaccines at all. There never has been. But yeah, that's one way to prevent it. The other way to prevent cervical cancer, for example, is with regular pap smears and HPV screening. And the interval for this varies. You still need to see your gynecologist every year for other kinds of screening, but for most people who don't have immunosuppression, who don't have risk factors, who haven't been HPV screens, once every 3 years is sufficient for a pap smear and HPV as long as it's negative. And that can catch the majority. The progression from getting infected with HPV to developing cervical cancer is about 10 years. So if you get screened, you can catch the changes, the dysplastic changes, or those changes that herald the presence of cancer before they ever become cancer. And you can have a simple excisional procedure that can prevent cancer in the overwhelming majority of cases.
This is the most important, is prevention, not to wait until somebody has the cancer. This is the best thing. So speaking of prevention, here Yusuf and I like to look at things differently. So especially in the last few years, there's a lot of talk about the gut, the vaginal flora. Is there any relation of our gut? And we know a lot of the diseases happen or start in the gut. So is there any relation, the gut microbiome with cancers, gynecological cancers?
Absolutely. We actually do a lot of this research at UM regarding the vaginal microbiome, and there's some research that's recently been happening with the relationship between the gut microbiome and the vaginal microbiome. And it's kind of the chicken and the egg thing, which makes it difficult to draw causative conclusions. But we know that in women with gynecologic cancers, their vaginal microbiome is completely altered. And then we know that with women with altered gut microbiome, their vaginal microbiome is
But
altered.
what are you doing about it? Do you try to fix this before as a prevention, or once they have the cancer, you also work on their gut?
Well, we don't once someone has cancer, it kind of shifts gears into working in ways that will optimize their response to treatment and whatnot. So during cancer treatment, it's not the time to work on the gut specifically. But in the prevention method, in the prevention phase, people to have a healthy gut flora means staying away from ultra-processed foods, staying away from inorganic fertilizers, phthalates, BPA, all these things have been shown to impact your gut bacteria.
Which is in plastics, like the phthalates and parabens and all of those.
It can be in plastics. No, well, actually, it can, as you're the expert on this. It can be in shampoo. Phthalates can be in shampoo. Like, it's a never-ending list.
No, I also read something about like if even during the treatment or the response to chemo or immunotherapy will be better if their gut microbiome is also. So have there been any studies on fixing the gut, whether by diet, by intermittent fasting mimicking diets, or certain types of diet that will be better for the treatment to be?
So a one-to-one direct treatment response with like a study that randomizes patients to during treatment or not, it's a little challenging to find a direct causation with response to treatment because you're talking about long-term outcome. However, there is significant data that with indirect measures. For example, patients who are on an all-natural diet with no ultra-processed foods have significantly more normal, if you will say, gut microbiome. And at the same time, their inflammatory markers in their blood is significantly lower. And so if you're trying to fight cancer, do you want your immune cells to be angry and inflamed and not acting correctly, or do you want an immune system that's ready to fight cancer cells? That's, in that sense, like what the best advice from a prevention point of view is keeping your gut healthy is really keeping your whole body healthy. So, there's a lot of foods that, there's a lot of obsession these days with macronutrients and making sure you're getting the right macronutrients regardless of where they come from. And that's very misguided because, you can get 30 grams of protein from ultra-processed beef, and we know that's associated with colon cancer and with other cancers for that matter. So
that's where people get into the supplements, and this is something that we're asked about. If I have cancer, can I take my multivitamins or can I take extra supplements? What is your advice on that?
This is, I practically talk about this almost, I would say, at least 30% of my chemotherapy visits is about this.
Talk about it more.
Yeah, we'll talk about it. No, I'm happy to discuss it because I think it's important.
Like a message to people that are hearing, can I take my supplements if I have cancer or not? Or are there certain ones that I shouldn't take? Some are safe. I know the answer to this is not easy,
it's actually quite convoluted. And here's the thing we have to talk about before we talk about that. Most of these supplements are not regulated. One. Two, most of these supplements, like if you look at even the ones that tout that they're data driven and there's like a small study that shows its benefit, that's usually done in 30 patients who are healthy and whatnot. None of these are big randomized controlled clinical trials or not even phase 1 clinical trials. So when you talk about any drug that comes to market, it has to go phase 1, phase 2, phase 3. Phase 1 trials is specifically looking at how these drugs, the pharmacokinetics and pharmacodynamics of these are, which specifically means when you take this supplement or this drug or this whatever substance you're going to take, what's the blood levels going to be, how is this interaction with other drugs going to be, and what's the long-term side effect. And we don't know any of these for a lot of these supplements. Patients think, oh, this is herbal, so it's fine. A lot of chemotherapies come from plants too, right? So Taxol is coming from Taxol. A lot of these chemotherapies come from plants.
Some of them are contaminated with lead and other things.
That's the other thing, is like having contaminants in it. So the short answer to your question is, can I take my supplements? Is I would say you shouldn't take anything without discussing in detail with your physician.
That's a good answer.
That's truly the case. I'll give you an example, and this is a real world example. I had a patient once who was getting chemotherapy, and her platelets, which is what helps your blood clot, were significantly depressed. And no matter what I did, no matter what growth factors I would give her, they kept on being depressed. And I reduced the dose of the chemo, still super depressed, delay, and that was significantly altering my ability to treat this patient. And one of the things that, because we really value the role of nutrition in cancer care at Sylvester, I've actually hired a nutritionist in the clinic. So there's a physical nutritionist sitting and sees every one of my patients. You don't get chemo without talking to our nutritionist first. So this is something that I didn't pick up on because, the patient comes in, she gets a med reconciliation by the nurse ahead of time, and then she comes talk to me. I look at what meds she's taking. So this patient went to speak to the nutritionist for some other gut issue, and the nutritionist uncovered that she was taking a herbal supplement. I don't want to say the name of the supplement because I don't want to create any fake news because it's just the N of one, right? Yeah. But we looked it up, and this supplement has been known to cause interaction with platelets. And when we stopped the supplements, her entire platelet issue was done. Yeah. And here's the flip side. If we hadn't discovered that, this patient was going to come off chemotherapy and be sent to hospice. Yeah. So these things can be dangerous just because they're from plants. The other thing that I wanted to mention for you is that always comes up in clinic is the whole role of sugar, right?
Yeah.
In general, in life in general, processed sugar is not good for you, right? Like we don't need to go into detail about this on this podcast. I'm sure everyone who watches this is very well aware of this. However, there's some data, some studies that happened in petri dishes where they have cancer cells sitting in a petri dish, and if you put sugar, they grow. Well, if you put sugar for brain cells, they grow. Like your brain can only take sugar. If you had the ability to regulate your blood sugar, then you would die every time you missed a meal. Right? So your blood sugar is extremely, so what I end up seeing is these patients going on these super restrictive diets because of some fad on the internet, like no sugar whatsoever, including like no fruits, no anything, that has carbs in it. And then these patients are losing weight, and that's way more dangerous than anything an apple can do for you while you're getting chemo. So that's
so say like focus on natural sources of carbs and simple sugars rather than processed sugars.
Processed sugars are never good for you.
Yeah.
But let me tell you this, if I have a patient who's getting chemotherapy and her appetite is down the drain and she's losing weight, I'm going to give her a supplement, a nutritional supplement that might have some processed sugar in it, because at that point, the most dangerous thing for that patient is for her to lose weight and to be in a caloric deficit. Like sarcopenia or loss of muscle mass due to malnutrition is one of the biggest risk factors for early mortality from cancer. And so for sure, there has to be a balanced approach to this. I'd say for people, you're asking me how to prevent cancer. When it comes to diet, ultra-restrictive diets have never been shown to long-term reduce your risk of cancer. However, all natural, most of the time, with minimal processed foods, and mainly from plants, I would say. That's the diet that's been shown. And I'm not saying become a vegan. There's nothing wrong with that, but I'm not saying that you have to become vegan to prevent cancer, but someone who eats a steak every day is probably not doing his colon cancer risk a lot of benefit, or his gut microbiome for that matter.
Not to give any medical advice on the podcast, because we're just educational, but are there like top 3 or 4 supplements that are safe that patients can take, and where are there like 3 or 4 that they should not use at all, or they might cause harm, whether it's harm to the treatment or harm financially or...
Yeah. So one of the biggest toxicities of all these supplements universally is financial toxicity.
Yeah.
That's one of the biggest toxicities. Like the amounts of money down the drain making expensive urine. That's what I tell patients. Like by taking 5,000% vitamin C of your daily requirement, you just made very expensive urine.
Yeah.
You didn't do anything. Like there's a limit to what your body can take. To answer your question, Yusuf, I think every supplement has the potential to be extremely harmful and can be helpful in certain scenarios. If a patient is missing zinc or vitamin D, a vitamin D supplement is very helpful. But if someone's normal in vitamin D and they take vitamin D extra, they can get toxicity that's going to impact their ability to fight cancer. It's going to impact their calcium.
Personalized supplementation is going to become, probably the key in those situations, because some of the supplements can be harmful. So, speaking of, all of this and, the new cancer preventions, and so as far as treatments are concerned, now the patient has cancer, so she needs surgery. Are there any new surgical techniques? I know you can talk for hours about this, but are there any new techniques, new biologicals, immunotherapies? Just briefly update us on this, and then we're going to talk about people that survive cancer. What can we do about their life? I
think, Labib, this is truly like a 10-hour thing. but I'll give you some highlights about things that might be shocking to people. So if you ask any one of your parents who had a hysterectomy, or any of the older generation who had a hysterectomy 20 years ago, 30 years ago, and the woman who had a hysterectomy today, what the difference might be. It might be in the approach to like minimally invasive surgery versus open surgery and that sort of thing. But for most part, surgeons have not really, like surgical technique beyond the adoption of minimally invasive and modern technologies hasn't really changed that much, that dramatically. And this is a big area of research of mine that I really focus on, is what we're finding out is that the biggest determinants beyond the basics. So I'm talking about, robotic surgery where it's appropriate, minimally invasive surgery where it's appropriate, using, ultrasonic devices and bipolar devices, all those surgical instruments and toys, if you will. Beyond that, like everyone's doing the same. Like we're all doing the same stuff. We're all trained similar institutions. There's some physicians who have more skill in certain types of surgery because they do more of it or whatnot. But for the most part, the act of surgery itself is pretty stable. Mm-hmm. The biggest difference that we see right now is an understanding that everything you do before and after the surgery has one of the biggest impacts on your surgical outcome. So, for example, proper nutrition before surgery is key, and proper nutrition after the surgery is key. Every single one of my patients who's undergoing a debulking surgery speaks to our nutritionist about proper nutrition, loading up on protein, iron supplementation when indicated, foods that are appropriate for gut health, proper preparation for their bowels before the surgery, and then post-operative immunonutrition to help support that stuff. The other thing is the role of exercise. Let me ask you a question. Do you run sometimes, or you bike sometimes? So if I told you tomorrow you're going to run a marathon, and you just showed up, what's going to happen? You're going to crash.
I'll quit.
You're going to quit halfway through. You're not going to make it to the end. And it's the same thing with surgery. Surgery is a marathon on the body. And we just talk to the patients, we see them in clinic, and we say, hey, we're going to go do a 6-hour debulking operation. And then we're surprised when things don't go perfectly. So what we're realizing now is actually there's so much role for a prescribed exercise regimen before surgery. Okay. We have women with ovarian cancer, I'm talking about 60, 70-year-old women who are getting to surgery doing deadlifts and squats. And I'm not joking.
Wow.
Yeah. And we found how much improved their outcomes come when it comes to hospital stay, post-operative infections, post-operative recovery, their chances of ending up in rehab. The whole concept of sarcopenia and making sure the nutrition and the muscle mass is adequate before surgery.
This applies to every surgery.
Everything.
Even cosmetic surgery,
yeah.
and when you optimize their health even before pregnancy, which is also a stressful period of time. So this is basically the surgical technique haven't changed, but you're talking about more maybe optimizing them before the surgery. For example, what about like hyperbaric oxygen? Is this something used when it comes to cancer, pre or post?
I want to correct myself in case I misspoke. The surgical techniques have changed somewhat,
yes,
right?
Yes,
but I think the impact that these like minimally invasive surgery wasn't available 30 years ago. Like we do a hysterectomy, the patient goes home the same day with minimal pain. That's not really a thing.
Maybe the planning of the surgery.
The planning of the surgery. So let me give you another example about planning of surgery. So in the past, if you went and you got a surgery, you remember when we were residents, we would prepare these prescriptions ahead of time, and like just oxycodone, narcotics, and do you know what the rate, if someone goes in for a routine appendectomy, you know what the risk of them still being on opiates 6 months later is? In the United States, it's 12%.
Wow.
So what if you're taking opiates, 6 months,
pandemic.
that's opioid use disorder. Yeah. Well, you saw that, wow. Let me ask you another question. If I told you a patient was just gonna casually try heroin for 3 days, what do you think her risk is going to be that she's going to be addicted in 6 months? It's the same substance. It's just a different mechanism of action, so we can't be surprised. So what we do, for example, in our practice is we implement something called enhanced recovery, where all of our patients before surgery, they're getting a lot of medications that impact pain in different non-narcotic pathways. We do a lot of tap blocks, a lot of regional blocks to numb all the nerves before we operate. And so post-operatively, and this is through data we've done at UM and it's been replicated in many other places, we have patients with stem to stern incisions that go home with no narcotics and no pain. They just take Tylenol and ibuprofen and nerve numbing agents like gabapentin after surgery. So those are the things I think have been more impactful. The surgical techniques have changed, but I think the thing that's a little different that I really think needs to focus on is this is the difference between getting 21st century surgery and 20th century surgery. It's not just the toys that you have. You have to do all that work before and after too. And then
hyperbaric
oxygen. Hyperbaric oxygen is a big no-no in cancer care. Whether it's justified or not is another conversation. But hyperbaric oxygen theoretically can increase your rate of cancer cell proliferation. So actually, it's an absolute contraindication to receive hyperbaric oxygen. Anyone with active cancer and any self-respecting hyperbaric institute will not accept a patient who has, even like, so we have, for example, vulvar cancer patients with really bad wounds who would really benefit from hyperbaric oxygen, but they have active cancer elsewhere, and so we don't recommend that at all.
I mean, we can go on and talk about the treatment for hours, as you mentioned, but we would like to touch upon a subject that's also important for cancer survivors, those who had undergone surgery, chemo. A lot of these patients lose the function of their ovaries, and obviously with that comes, you know, menopause. That's not necessarily a natural type of menopause, and loss of estrogen, and obviously all the consequences. The biggest question is hormone replacement therapy. I know you wrote the national guidelines, and I know we can talk hours and hours, but give us a summary. Hormone replacement for cancer survivors: estrogens, progesterone, and potentially testosterone.
Excellent. So this is another area of medicine where fear has taken over so much. You know, in the past there was this WHI study, which was we have a lot of criticism.
This is even without cancer, people
without
fear
cancer,
hormones.
fear hormones,
Imagine
right? So that really swung the pendulum in another direction, and then I think now slowly with a lot of the education that we're doing on the subject, things have changed. When you talk about induced menopause, which is, as you know, the technical term for any menopause that's occurred externally, so whether it's due to radiation, whether it's due to surgery, whether it's due to chemotherapy that knocks out your estrogen, your ovarian function. The difference between natural menopause is it's a slow teetering of your estrogen levels until it hits an inflection point that the patient feels symptoms.
This is abrupt.
This is abrupt. Like all of a sudden your estrogen's here and next day it's down there. Even in cases where the woman's postmenopausal, there's still ovarian function up to the age of 65. So there's very often, well, you were menopausal. Why are you complaining about menopausal symptoms? Well, because her ovaries were still doing stuff, right? They were still producing hormones. They were still giving some sort of function. So we know from healthy women that removing ovaries before the age of 65 increases your risk of dementia, increases your risk of osteoporosis, increases your risk of heart disease, increases your risk of vaginal dryness, genitourinary syndrome of menopause, poor quality of life, poor sexual appetite, poor sexual health, a plethora of everything.
A miserable
right?
life.
Well, I mean, it's suboptimal, let's say.
So on top of their cancer.
On top of their cancer. So, but historically, people immediately thought gynecologic cancer, hormone receptor cancer can't do chemo.
Yeah.
So first of all, cervical cancer affects young women. Women are usually in their 30s, 40s, or 50s. So most of the times, whether they get surgery or they get radiations, a lot of times they lose their ovarian function. So radiation will knock out the ovarian function. Sometimes it's not, always indicated to remove the ovaries. So one of the ways to do that is if you don't need to remove the ovaries, don't remove them. So the risk of metastasis of cervical cancer to the ovaries in the most common subtype of cervical cancer is less than 2%. So if it's not involved, don't touch it. And then that's the first way to prevent all that stuff. But then one of the hallmarks of cervical cancer changes on a molecular level and on a proteomic level is that they lose the estrogen receptor. So literally, cervical cancer cells don't respond to estrogen. Mm-hmm. And so if you're treating someone with curative intent, well, they're going to live less if they don't get estrogen. So when we wrote the guidelines, we said cervical cancer patients, we made it very unambiguous, must receive estrogen replacement therapy. That being said, if they still have their uterus, we need to supplement them with progesterone to prevent the risk of uterine cancer. When it comes to ovarian cancer, there's actually randomized controlled data that showed that women with ovarian cancer receive standard treatment, same treatment. The only difference is these women got estrogen replacement therapy and these women didn't. And we're talking about women in their 50s and 60s. Like, so if they are candidates for hormone replacement therapy, they have a higher cancer-specific and overall survival if they get hormone replacement therapy. And you have to do the hormone replacement therapy that's appropriate to the patient, right? Like, clearly there are contraindications. A patient with a history of breast cancer should never receive any hormone replacement therapy. There are certain kinds of ovarian cancers that actually do respond to estrogen, like endometrioid. So it's really it's a tailored approach. I'm not saying every ovarian cancer needs to get hormone therapy or can, but the majority of them can. Majority can.
This is the important message. Yeah.
And then when it comes to endometrial cancer, this is the one where actually there's not controversy, we know, but endometrial cancer is estrogen responsive in the overwhelming majority of cases. So for advanced stage cancer or high grade histologies, those patients are never candidates for estrogen replacement therapy. Systemic, and I'll get to that in a second.
Meaning they cannot take it by mouth.
They cannot take it by mouth or by patch or by pellet or whatever, anything that goes into the bloodstream. For early stage endometrial cancer, they are candidates, and there's a randomized controlled clinical trial that never completed because of the WHI results that shows, but for the most part, there was no difference in the outcomes between the patients. So it is safe for the most part. And so if a patient's really young or has horrible symptoms, or she's like 50 years old and all of a sudden she's feeling terrible, you are able to give that.
Yeah.
The flip side is vaginal estrogen can improve every aspect of the genitourinary syndrome of menopause, which just for the audience is things like recurrent UTIs, vaginal pain, dyspareunia, vaginal dryness, all those aspects of heaviness in the pelvis. Vaginal estrogen, the absorption systemically after the first few weeks is very low, and it immediately, within like a month, it improves your vaginal milieu, if you will. It brings back the vagina to how it was when it's estrogenated.
So for those who absolutely cannot get estrogen, whether by mouth, a patch or pellet, what can we do? Are there any alternatives that we can do?
Absolutely, yeah. There's an infinite amount of alternatives. Well, I shouldn't say infinite, but there's many alternatives. And it really depends on the symptom that they're having. So someone who cannot get estrogen, if they're having vaginal symptoms, you can try vaginal estrogen. But let's say she had a high-grade endometrial cancer that was in the vagina and you don't want to give her vaginal estrogen. Well, there's a lot of other products on the market that you can give. One of them is hyaluronic acid. So similar to how people use moisturizer on the face, you can think of hyaluronic acid to the vagina as a moisturizer for the vagina. It's going to improve your water retention within the vaginal epithelium, and it's going to improve the symptoms. Other options, for example, for hot flashes. There are so many non-hormonal options for hot flashes, including SNRIs or gabapentin, and actually oxybutynin can really help. There are medications to help with sexual appetite and libido, I should say, that specifically target that, the non-hormonal on the market. And truly then you have to go into the other aspects. So someone who has induced menopause needs to get DEXA scans to check for osteoporosis more often, and there's medications to help with osteoporosis. Same thing with heart screening and making sure that the patient's appropriate.
I mean, this is great news. At least there are, options, hormonal, non-hormonal, for these patients, and there are guidelines. So I think it's, people should ask their physicians about it, not to, live in this suboptimal life like
Absolutely.
Like we said.
It's not just a quality. Here's the thing, it's not just the quality. Quality of life is the most important, but it's not just quality, it's also quantity of life. And this even is more important for patients who are previvors. So you asked me about the cancer patients who are survivors. Previvors are patients who have a hereditary mutation, so you have a BRCA mutation, who need to get a risk-reducing oophorectomy at age 40, for example, or 35. Well, 35-year-old who's going to expect her to live her whole life, she's going to live without estrogen from age 35. That's dramatic. And so in the guidelines, we also made it very clear that it's safe and it's acceptable. And sometimes you have to alter the surgical plan to simplify the hormonal therapy.
I mean, I think we always should remind people about these things. We should always bring them out because patients are afraid, some doctors are afraid, and then you get all these patients who have to deal with not just their cancers, they have to deal with all the sequelae and all the problems that come from menopause and the lack of estrogen.
I think this is an area where there's fear rules. Even within physicians. I can't tell you how many times I get referrals. Oh, my doctor told me I absolutely cannot. To be clear, again, not everyone is a candidate for hormone therapy. If someone has a history of breast cancer, then that's not really an option.
I mean, we can talk about, cancer for hours and hours with Dr. Sinno. But I think, the message that we want to, tell the audience is like this dangerous disease that people fear, has a lot of solutions. Things are improving. You can, fight it either through, prevention, taking care of your gut, of your health, optimizing your health before surgery. Even after you have the surgery and the treatment, there are options. So, Dr. Sinno, really, this was a very, fast, podcast. The time flew so fast, but hopefully we can maybe do part 2 of this and talk more about,
Absolutely.
Other options. I hope everybody enjoyed it, and it's time to say goodbye, I guess.
Thank you again for being with us, and I guess we'll see everybody in the next episode. Hopefully, with another.
Happy to be here. I'll leave you guys with my standard closing remarks, which are: there's more in our armamentarium today to fight cancer than ever before. Whether it's with surgery, chemo, immuno, targeted agents, more than ever before. We understand better the role of mental health and nutritional health and gut health and more than ever before. And so the future is not only bright, it's glowing. You have more hope today if you've been diagnosed with cancer than you've ever had in your life. And I hope no one ever needs us, but if they do, we're here for them. So
that summarizes everything. Thank you so much.
Thank you.
My pleasure.
Thank you.
My pleasure.
Ciao.